Karen, I was going to wear my aortic coat sweatshirt, but I put on red just because it's Go Red Month.
That's perfect.
So next time I'll wear the sweatshirt.
I think that sounds great. So we are live now. Karen Anderson here with Aortic Hope, and I'm so excited. As you see, we've been chatting a little bit. We've got Dr. Stacy Fisher here with us, and I'm going to let her tell you guys a little bit about yourself. But before we start, this is brand new format for us on our YouTube channel, Aortic Hope. We like to call it AHTV. So we have a lot of fun, wonderful ideas and other live events lined up throughout the year for you. And we're excited that you've joined us. Please don't forget to like and subscribe to the channel. You do have an opportunity to ask questions with the comment button below. And there's also a link if you want to ask some anonymous questions. So that hasn't changed. But before we get started, I do want to tell all of our community members, everyone who's been affected by the weather, people who have family members that have lost power, our thoughts are with you. Please try to stay safe. It's just stay safe. It's been crazy out there. And we're going to talk about weather a little bit too when it comes to our conditions. But welcome, Dr. Fisher.
Thank you. Great. It's so nice to be on AHTV.
It's so exciting. It's kind of fun. It's kind of different from when we used to sit together, but at least we're here. So this is good. A little bit of a scenery when we would get really close to fit into my little camera on my computer. Why don't you go ahead and tell everybody a little bit about yourself and the team that you're on and what you're doing, and then we'll take it from there.
Sure. I'm Dr. Stacy Fisher. I'm with the University of Maryland School of Medicine and the Cardiovascular Disease Center. I'm an associate professor of medicine and pediatrics. So I specialize in adult congenital heart disease, or people that have structural heart disease. And through that have really come to take care of many people who have predispositions to aortic disease, such as genetic diseases, Marfan syndrome, connective tissue disease, Ehlers-Danlos, and also just young, healthy people that have genetic predisposition to aortic disease. So through my career, I've seen wonderful advances in technology. And one of the things that I thought we really needed to help was to help try to make surgery safer. And we have been doing 3D printing to try to help surgeons have models to understand and use as platforms to work with. So hopefully we can transform many of the procedures to smaller or more direct procedures, or to catheter-based procedures. And I certainly want to be on the team that helps move it forward.
That's wonderful. I know that, I want to say last year we talked a little bit about that, and I know things were really getting started and taking off. So I just took a little note because I want to make sure we touch upon that too. So just like the formats we've done in the past, we're going to sit and talk a little bit, and then if questions come in, we'll answer them, and then people get to review this video. So at least they're going to get a chance to hear all of that great information. So one of the things I want to talk about is when people have an issue, whether it's a dissection or they've been diagnosed with an aneurysm, usually more with the dissection patients. Some patients in the community, they tend to be confused. I've had people tell me that they thought the only doctor they should see would be their thoracic surgeon, and they realized that's not my cardiologist. So if you could explain a little bit and define the role of a cardiologist and what really makes a well-rounded team in an aortic disease center, or what would you need if you didn't have a center to go to?
That's a really good question, and the models are really just forming. So we even talk among ourselves with what do we need, who needs to be part of the team, and how do we move forward to make sure we really have comprehensive care. And there are many parts of the country that don't have a center. So a cardiologist is somebody that can help guide you in the screening, can do the imaging for the most part, and can help guide you with testing. If people have aortic disease because of hypertension or atherosclerotic disease, and that runs in your family, and it's a clear explanation of the disease, that's one thing. And a cardiologist really should be primary in preventing further problems or secondary disease. If you're not in that category, you really don't have a reason that explains why you might have aortic disease, or there's a really strong familial tendency for people to have aneurysms or dissections, then it's really worth seeing a geneticist or working with somebody that has familiarity with genetics and can look at why you have this so that not only can your disease be understood better, for example, certain genes will also affect vessels in the brain or other vessels, and certain genes really stick to the thoracic aorta as far as which parts of the collagen or structure of the vessel they affect. So it can help give you smart screening, and it can really help give you smart family guidance. So genetics or a cardiologist that works with the genetics would be an important part of that. And then because the tendency for injury to the heart is so strong from the dissection itself or problems with the heart that lead to the dissection, the heart screening is really a very important part of other vascular screening. So
it sounds like
on the cardiologist for that part.
So no matter what, you're going to have a cardiologist. Seems like it's a definite person. If you've had surgery, you're going to have your surgeon. If you're waiting, no matter what, you have your cardiologist. And you could end up with a cardiothoracic surgeon or a vascular surgeon. It really depends on the situation.
Well, it depends on what part of the aorta is involved. So if it involves the ascending aorta, it's a cardiac surgeon. Okay. If it involves any other parts, it's going to be a vascular surgeon. In many places, it's a team where you have both, or they work together, or they decide who's going to work on what part. Many surgeons will see you right after your surgery and don't continue to follow you. So many areas of the country, that is the model. And then you would count on your cardiologist and a lot of times your vascular doctor, vascular medicine versus vascular surgery to guide your screening. And that's where understanding why you had this will help give you smarter screening.
Mm-hmm.
So we're very lucky where our cardiothoracic surgeon and vascular surgeon that are part of the Aortic Disease Center continue to follow patients.
Mm-hmm. And I do hear patients often that once they've had their surgery, they really don't necessarily even have a follow-up. Everything's going through the cardiologist. And for people that work with a team and have a dissection center, that just seems so foreign because everybody's intermixed, and that just seems to be a one-stop shop.
Right. And the cardiologist, that's okay as long as you're really getting the screening. For example, a Marfan's patient should have annual screening. Somebody that still has residual dilation of the aorta should have annual screening, or even more than that if there's an area that has suspicion of expansion. So it's really important that you're getting screened and that you're not hearing, well, you're fixed and you're done forever, go have a nice life. Because that's where people show up in trouble 5 or 10 years later.
Right. Now, talking about the genetics, because you just mentioned that, I do understand why patients want to be genetically tested after an event happens, but I'm wondering your thoughts about having your children or your siblings tested, or do you think that they're just going to be treated as if there's something wrong anyway? Because the vast majority of us do not end up showing any definitive genetic reason. It's just familial. We don't know what it is. So do you believe in extending that testing, or just still doing a firm screening?
So I believe strongly if there's not a clear reason for the dissection in doing the testing, and you have to use the testing in a smart way. So if you are positive and you have one spot on one gene that clearly is causing this problem, you can check family members for that spot. And if they're negative, they're home free and clear. They don't need screening. They know that they're okay. So it's wonderful to actually have that information because the people that need screening will get the screening, and the people that don't have this hanging over their head. If you do the testing and you are negative, it can be a few things. Number one, it could be that we just fish wrong and there is a gene, but we don't know what the gene is. It could be that this really is not a familial problem. This could be a structural problem in an area that expanded. It could be that there's some other autoimmune or inflammatory problem that is not a familial or genetic problem. Mm-hmm. So it does make it much less likely that your family members are going to have the same problem. But because it can be familial and we don't know all the genes or all the structures to check for, we generally recommend screening for all first-degree relatives, so parents, brothers, sisters, children. And it really would depend on what what type of aneurysm as well. So whether it's abdominal or whether it's thoracic, or whether it's in the brain, there are some different things we look for, some different signs or symptoms. For example, hypermobile Ehlers-Danlos, rarely associated, but can certainly be associated with aortic dilation, and we don't know any of the genes for that. So then we can do a physical exam on family members. Are they hypermobile? Do they have any of the connective tissue features? And then we would recommend really just an echo. The echo, if they're fully grown, about every 5 years. If they're not fully grown and the incident person had early aneurysm, then you could do it more often while they're growing, because there's more changes in growing people. And when they stop growing, things stop remodeling so fast. The other thing is, if somebody with a family history of aneurysm develops high blood pressure, you would want to more fully screen them at that time, because you're not sure how long they've really had it and if it's had effects on the vessels themselves. So that's where you do have to personalize much more. So, for example, if you're negative and you don't have a definite reason, you certainly want to look at other things. Is there lupus or rheumatoid arthritis, connective tissue disease? Those have some familial tendencies, but not as much as the aneurysm. And it's probably more the autoimmune effect or the inflammation that causes the injury to the vessels. Does that make more sense?
Yes.
So you would look for that disease rather than the aneurysm.
Right. So for instance, I have Crohn's. So people in the IBD world, I've been trying to express this to a lot of them just to have the conversation, because it makes sense to me that if you have a disease that's inflammatory in nature, that your heart is working harder, that you could then, I guess, develop an aneurysm. I mean, am I right in my thinking for that?
Right, and we've also talked about the possibility of some of the antibiotics or medications having a link, which we're not really sure of yet. Yeah. But I think as we understand the structure better, we're going to understand better. So for like you, I feel free to share, you went and had your family screened. Because you care about your family and you wanted them screened. So you're open with them and you were willing to bring them and have them screened. And I think it's incredibly important. It's also important while they're getting screened, they get a good look at what is their overall cardiovascular health and how do you improve their life expectancy and their health over time as well.
Right.
So you get a lot of benefits out of that.
Yeah. And there is an organization that's called Think Aorta US, and one of the driving forces behind that is, especially now while we're all home with our families, Think Aorta, Think Family. And this would be a great time to have those conversations about your history, your medical history, to determine, if you found out that your grandfather, just suddenly passed away, no explanation, or somebody else had a brain aneurysm, it might make sense to have these conversations and talk to a geneticist or speak with one of your physicians to see about a proper follow-up.
Another thing to think about, the hardest situation with the genetics is where somebody has an aneurysm and dies. And what do you do with the rest of the family and you don't have that person anymore?
Right.
So if they have done this genetic screening ahead of time, certain genes, certain things about them. And again, everybody else can be smarter about their testing. If you don't have that, then you end up expanding the testing. And yes, you can do kind of fishing expeditions on the family members. We try to do that mainly if they have features of some of the other connective tissue problems. So for example, if you have somebody who had the death of a grandfather at 35 and they have a lens dislocation and they are very nearsighted, then you might do the fibrillin gene. If they have a heart-shaped uvula, then you're thinking of Loeys-Dietz syndrome, and you may just do that gene. And if they really want to be checked and you don't know, then there are some options, and there's even a prevention panel. It's under prevention. It's a prevention medicine panel. You can do either heart or heart and cancer. So a lot of people will actually do egg screening, for example, and they will do a full profile because why, if you're going to do egg screening, wouldn't you screen for the common cancer and heart genes?
Right. Yeah.
So they don't screen boy, girl, blue eyes, brown eyes, but they screen heart and cancer genes. And then you could actually have egg harvest and have the healthy eggs put back in and avoid the sudden death risk.
It's amazing. That's
Yeah.
just, it's amazing. It's
So
amazing.
you have to really think about it. You
Right.
can't just go and, you know, naturally have a child if you have one of these known genes and you want to avoid passing it down.
Yeah. Right. So one of the things we always talk about, we do the same thing because every time we meet to have these conversations, there's a whole new group of community members. So this is the first time for some of them, which is ironic because they have a doctor, but they don't really get these types of conversations. So one of the things is when somebody has an aneurysm, if they've got high blood pressure issues or not, or they've had a dissection, they're going to be talking about blood pressure. So let's get a little bit down to basics about blood pressure. What does it define? What does it mean? What's high? What's a spike? So let's talk about a lot of those things surrounding blood pressure first.
Sure. So normal adult blood pressure, you really want in, say, the 120s, 130s or less for the systolic number, and the diastolic number, which is the bottom number on the blood pressure measurement, you really want to be 80 or less. Everybody's blood pressure fluctuates, and it should fluctuate. You don't want your blood pressure just flat. You really want it to be able to go up when you're exercising, and then it comes down below where you started. If you're suddenly startled or anxious, it should go up. It should actually help support you to do more. And basically what happens is your peripheral vessels constrict and the blood goes up to your brain and the pressure goes up. So when you're stressed or active, it should go up. What you don't want is for it to just stay up. Mm-hmm. So the number you're treating should really be your average blood pressure number. You don't want to treat every single number. At the same time, you never want to see numbers of like 180, 200, and you want to keep that bottom number, the diastolic, well below 100. Because those spikes, if you have an aneurysm or dissection, can increase the size. They can certainly increase the shear. And there are people with aneurysms that at high blood pressures have chest tightness, and at lower blood pressures are absolutely fine. They can actually feel the wall stress. Not many, but some. So you really do need to look at and monitor your pressure. If you have had a dissection that involves the vessel to the left arm, the left subclavian, sometimes the left arm blood pressure is lower than the other blood pressure. So you do want to know what the pressure difference is between your arms at baseline. And most people generally want to follow their right arm blood pressure. So again, with dissections, it can be a little bit different, but you want to know and you want to check and make sure that you're actually measuring an appropriate blood pressure to treat. It's important to have a cuff to keep the logs. The thing that you can modify the most in your diet that will help is salt. Salt immediately raises the pressure. If you ever have very low pressure, salt will bring it up. If it's high, salt will, getting rid of salt will bring it down.
Now, you had once mentioned to me, because I had called you, about a substantial difference between arms. So first question is, what is considered dangerous? And second, when you have a difference between arms, I think you had mentioned to me, you always then want to go with the higher arm as if you're finding that often, then that's the one arm you want to go with. Whereas I used to go, and I used to look for the lower number and say, yes, I'm lower, but realize, no, I'm actually higher. So what are your thoughts with that?
So that's a really important question. In somebody who has never had a dissection, and aneurysm patients have not dissected, it's a very different situation. In somebody who has a normally connected aorta, not a coarctation or anything interrupted, the blood pressures in the arms really should be the same, unless there's been trauma or a shunt or something surgically done that changes the blood flow to either arm. So they really should be the same. The dissection, as it spirals around from the top around, it can dissect into the vessels of either arm, and it makes a true lumen and a false lumen. So as it dissects, it's tearing between the layers of the aorta so that the intimal layer, the inside layer, flaps in, and it makes the vessel small, and it makes the flow less to that side. So you may have an artificially low blood pressure to the side where the dissection is involved. And generally after a dissection, you will have a very stable difference in pressures between arms if you have a difference. So it should stay about what it is, and you should have good flow. You should be able to feel the pulse, and you shouldn't get tiredness or aching in that arm with the lower pressure when you're using it. So those are things that would make me concerned about the arm itself. But as far as the blood pressure and what you're treating, you want to treat what the head and the heart are seeing and what the central vessels are seeing. So you want to treat the arm with the better flow.
Okay. Okay. So let's talk about treatment. What are the typical prescriptions and drugs that one would go to? And we all would agree, the community members, that when we wake up from having a dissection, we're all on labetalol, enormous amounts of labetalol. I think that is just the standard that people go to. We don't know why. And then we all come home and the majority of us end up on losartan, and we don't really know why. Those conversations really don't happen unless a survivor or a patient presses their doctor. So maybe you can take a minute and explain the different types of drugs, why they're used, and then the timing, because the timing is also a very interesting topic.
You ask great questions.
I think these are all questions I want to know for myself.
I love hearing that impression that we wake up and there's the labetalol. It's true. I never thought of it that way.
Yeah.
So labetalol, one reason we really like it is, number one, it's fairly short acting, which is why it's also not a once a day drug. It comes as a very wide range of doses, and it comes as both an oral and an IV. So when you have somebody going through surgery and you need something that works pretty quick but doesn't last too long, so that you can use it with different amounts of anesthesia, or if they wake up and they're terrified and their pressure shoots up right around the dissection, you need that pressure perfect. So you want something that you can titrate very quickly and that you can use immediately acting amounts. The labetalol is an alpha and a beta blocker, so it really lowers the stress against the wall. You may not know a lot about the person that's coming in if there ends up being cocaine in the system. A pure beta blocker can have unopposed alpha, and you can skyrocket the pressure. Or if somebody has something called a pheochromocytoma, which is a tiny tumor that can raise the pressure dramatically and cause a dissection, this would still work. So it has a lot of appeal for somebody that you don't know as well. It's very nice to the kidneys. It's very effective for blood pressure. It's safe in pregnancy, and you can titrate it a lot. But it's meant to be frequently dosed. So it's the 2 or 3 times a day medicine, which is why it's often changed. But it can be a long-term medicine. It's used frequently in pregnancy, and it's a very good drug. So that's labetalol. We always look at things that have beta blockers that decrease the stress against the wall of the vessel. Beta blockers and ACE, ARBs, or nifedipine have been the drugs that have been proven in the literature to lower the wall stress. What you want to do is you want to take the stress off of the stretched wall. So those classes of drugs are the ones we prefer. So the ACE inhibitors, you have really 6 of them. Some of the most common are the ones you mentioned: losartan, irbesartan, valsartan, telmisartan, olmesartan.
Right.
And you have your ACE inhibitors, which are your lisinopril, enalapril, quinapril, ramipril. They're considered fairly equivalent. And again, they reduce the wall stress. So a lot of times you'll get whichever one the providers are most comfortable with. They're all generic at this point. So they're generally affordable. It may be that the hospital formulary has one versus another. So they're very good medications. They take a little bit longer to get into the system. They also help the heart remodel and recover from any injury it's had from high blood pressure. So they're very attractive in that way. You can't use them with advanced kidney disease. They can raise the potassium. So your kidneys have to be able to clear potassium normally to be on that type of medication.
So we did talk about the timing, because I always found that very fascinating, which is why it's so important to take your medicine at the time you're supposed to take it. And that's because certain medications go into effect different times of the day? They're not like a Tylenol. You can't just take your blood pressure med and think 20 minutes later you're going to feel great if there's a problem. So maybe you can explain that a little bit.
Sure, that's really important too. So that a lot of people think, if their blood pressure is high and they take their medicine, it should be normal 20 minutes later. And they start dosing their medicines that way and taking extra medicines or skipping medicines. And it wreaks havoc on trying to get the blood pressure controlled. Many of the medicines peak in their effect from anywhere from 2 to 8 hours after you take them. Some of them are cleared over 8 to 12 hours, and some of them are cleared over 24 to 30 hours. So, for example, a medicine like amlodipine has a much higher half-life. It lasts a long time. It really is meant to be a once-a-day medication compared to losartan, which is really meant to be a twice-a-day medication based on its pharmacokinetics.
Mm-hmm.
So that's really important. And you do have to, if you want to time it for when you're getting your peak blood pressures, you have to look at the pharmacology of the medication.
Okay. So if you're having problems because you should be tracking your blood pressure every now and then anyway, that's a good conversation to have with your doctor, because you might need to adjust the timing or the type of drug or what have you.
Right. And a good way to do that if you're having trouble is just to take a week and take your blood pressure 3 times a day, no matter what's going on. Make a log that says time, date, pressure. And try not to look too hard at the numbers. And then at the end of the week, look at all the numbers and figure out where are you peaking. Most people, even though you slept well, you feel good. Most people with the circadian rhythm, the blood pressure is highest first thing in the morning. So that's why a lot of blood pressure medications are timed at night. So they're timed at night, so they'll peak right as your blood pressure is peaking in the morning. And again, that's not intuitive. It's not what you would think, but it is what, it is what it is. And a lot of it is actually hormonal and based on your body's chemistry more than what you think it is.
And I'm totally the opposite. I come soaring up by that 6 o'clock, 7 o'clock. And then I sit there and I think, oh my gosh, look how high it is. So that leads the question of, when you know it's not a spike and it's not time for your meds yet, how worried should one be when it's that whatever time of day it happens for anybody, but for me, 6 or 7 p.m. and I see, I'm hovering here at 145 for no reason. I didn't have a salty meal. I've been pounding water all day. I'm laying in bed watching benign TV. How do you know, this is a problem? This isn't getting better. How concerned should I be? Is this now a trend? What does somebody do with that?
So that's exactly what you do, is you make that log for the week, right? And you take your medicines right on time every day. So you can see on your medicines, whatever they are at this time, this is what you're doing. And if you're spiking every day at 4 to 6 p.m., then you're going to increase your morning medication, even though your morning's not that high.
All right.
So your morning's perfect, but your afternoon's high, you're going to shift your medications more to the morning, where we generally shift them more to the evening because the morning's usually the highest. Or you may need to keep them and just increase what you're on in the morning.
Okay.
And there will be different times in life where you do change which medications you're on based on the particular diet, how much stress you're under. There are school teachers that in the summer are off of all of their blood pressure medicines and go right back on in September.
And the key is just to have that conversation with your doctor. There's a lot of community members, I think, that suffer in silence because they're told, take this, and then they're left with a bunch of side effects. They don't understand. Maybe they're coughing, maybe they're having headaches, who knows what it is, but they take it and they don't realize that there are a plethora of medications out there, and you guys can work out a whole new cocktail for us if we need be. They just need to bring the topic up.
Right. And it is a cocktail, right? And it's got to be one that tastes perfect for you.
That's right. Right.
Because there are side effects of all these medicines. And part of why there's so many different medicines is that people are very sensitive to them. Sometimes you can just take a high dose of one medicine, but sometimes you actually want the effects of multiple medicines. So, for example, if somebody has a weak heart muscle, which you could have gotten from the shock or from the dissection, if someone's heart muscle is weak, you really need a lot of different mechanisms to try to restore the heart muscle and heart function. So you're trying to add this cocktail together to decrease the inflammation, to decrease the work, to improve the afterload, to get the heart stronger. And you do the same thing with the endothelium. You're trying to decrease inflammation. You're trying to decrease afterload so that the pressure is off of it, and you're trying to decrease wall stress. And then there are people that may have a very high blood pressure from the adrenal glands or from the pheochromocytoma. And then you really need to treat those specifically, and those are different blood pressure medications. So
there's so much.
Right, there's so much, but again, this conversation between you and your doctor, it has to happen.
Right.
And what never gets fixed is when people treat every single number.
Yep.
People get really sick like that, and there have been times through history where people would use like clonidine under the tongue or sublingual procardia to treat every high blood pressure number, and the stroke risk in those patients is much, much higher than the people who will have a little bit of high blood pressure here and there, but don't fluctuate so much. So it really likes consistency.
So, and that's the whole thing with the log. So I think what makes sense is, you know, you can have somebody, I'm just going to make somebody up that could be a little active, trying to move some laundry, trying to do a little bit of housework, and they just don't feel well and their blood pressure's up. The first thing you should probably do is just put yourself in a position where you can relax, take a minute, because going up is normal. You're moving. That's a good thing. You want to exercise the heart, but you do want to take a few minutes and just decompress, relax, wait, and then take your blood pressure again and see if it's normalized a little bit. So,
right. And if you're feeling badly with it, that's a sign that you may be doing a little bit more than you're ready to do,
right.
Or it may be a sign that you're undertreated.
Yeah. Okay.
Right? And you can address both of those things. And if you really can't tell, your doctor could put you on a treadmill and do a stress test and just check the blood pressure every minute and a half, which is standard on the stress test. And you can tell if the blood pressure is undertreated because it should have a normal increase. It shouldn't increase more than 70. People are shocked by that number, but that's really the number that you want to stay. If you start normal, you know, that's above that is what's considered a hypertensive response to exercise when you're pushing it.
Never even heard of that. So you're saying if you're normal when you're medicated is 120 over 80, just to throw out a good number, and then you put somebody in the treadmill for just a regular exercise, we're not, you know, runners in a race, it shouldn't go up more than to 190. Is that what you're saying?
Yeah.
Wow, that's a pretty high number. So
when you're really pushing it, that is what I'm saying. Now, if you've had a dissection, we want to blunt you with medicine so that you don't go up to 190 and you don't have a normal response. It protects your vessels, but you may tire before somebody else.
Yeah.
Because you also aren't getting that huge output that the 20-year-old that's going up to 170 is getting.
Right.
Right? So it is
those
different.
days.
And it's a different level of expectation that you don't want to change any expectations.
Right. Exactly.
We want you to be able to exercise, but honestly, after a dissection, you want to be kind to your vessels. You don't want to test them. So you want to exercise moderately. You want to warm up or cool down at a moderate level so that maybe if your blood pressure is really well controlled and you're usually in the 120s, you're going up to like 150. That would be a normal level. It would give you a really nice range for exercise, for endurance building, for fitness, but it wouldn't tear apart your vessels.
So then that leads to the next thing. I know you love this terminology. When you have that night where you feel pings and pangs, and the community, we love talking about that because there are times, and it's worse now because of COVID, where you do not feel well. It has just been an off day. Many of us have it. We know when we wake up, it's just going to be a great day. And then the pressure goes up, and maybe you're starting to have chest pain, and it's not going away in a certain period of time. So what are the parameters for these new sensations you're feeling, or if you're years into recovery and something doesn't feel right, what are the parameters that we talk about with pings and pangs on when you should, regardless of a pandemic, go get something checked out?
Yeah, I love this question. And again, in the pandemic, people have been afraid to go to the hospital. So having these discriminators is really important. But one of the biggest messages I want to stick in before we get back to the question is don't be afraid to go to the hospital. If you're concerned about your heart and your vessels, you go. And hopefully we will have a situation where we can get everybody vaccinated. Hopefully, the staff at the hospitals have now been vaccinated, and the risk is actually going way down.
Right.
So as as you get vaccinated and your staff is vaccinated, the risk is going to be wonderful again. But in the meantime, if you're worried about your heart, you go. So things that you can ignore, the pings and pangs that everybody's going to get. People get electric shock type feelings. It can be a lot of different places. They just last a second. Those are normal sensations you've probably had your whole life, but you realize them now because you've had this happen. Anything that hurts when you press on it that you can reproduce is muscular, right? If you can put ice on it and fix it, it's a muscle.
Right,
or a bone or inflammatory something. So if you can move a certain way and press on something and reproduce it, it's okay to call that muscular. If you have eaten tomato sauce and have a burning and Pepsid makes it go away, it's okay to call that GERD as well.
Right.
If you're feeling a burning or pressure and you haven't had that happen and it doesn't go away, don't just call it GERD. You need to go get it checked. So if you have something that's lasting more than a few minutes, gets worse as you get up and move around, comes as a repeated pattern, like comes and goes, but comes when you're active or when you're stressed, is not associated with food. And it's intensifying. That is something that you call EMS for, actually.
Well, that's happened a lot to me, but now I have the GI cocktail at home at my beck and call. So I can, if I have a situation, try to drink some of that and then wait another 10 minutes. And if it resolves, great. And if it doesn't, then I text you. That's how I do it.
Yeah, and it's also, it's really hard when you have a GI issue and you have a dissection.
Right.
It is really hard for you to discriminate. And sometimes it's hard for us to discriminate too. So sometimes having that conversation just helps work out. What have we tried? What have we tested? How bad are you feeling otherwise? Have you checked the blood pressure? Do we know if something else is going on? And if we really can't tell, then it's better to go get checked out. This is one where you really don't want to play with it, because if it's extending, it's life-saving to get there early. Right? And we have done some extra evaluations in the ER. We try not to. But when we have to, we do it.
Right. So we just touched upon COVID, which is really important because I'm looking to do a live event with community members who have had COVID. I think it would be a great, like a town hall conversation for us to just talk about it, because so many of us I've had people whose spouses do not have aortic disease and they did far worse, but it runs the gamut. It's amazing that it's not because I've had a dissection that I did a little worse than my husband who just had cold symptoms. It's, you just don't know how your body's going to react to it. And so the community members are often confused, thinking that because we have aortic disease, that we're more susceptible to getting COVID, when that's not really the case. I think we're more at risk for having complications. So can you differentiate that and explain?
Sure. So COVID, the virus itself, it likes people. It likes everybody. It really does. It's a very interesting virus where almost 40% of the people that have it don't have any symptoms. Nothing. Their immune system fights it, but they're able to carry it. And they're kind of silent infectors. They don't realize they have it. They have zero symptoms, really zero, even looking back. And everyone around them just starts getting sick.
Right.
So it's really a very diabolical virus. People have their immune response to this virus that causes a lot of the damage that happens. It gets in these ACE2 receptors. It has a very strong tendency towards the lungs. Even some of the asymptomatic people, if you do CAT scans, they actually have pneumonias. Wow. It has a lot of neurologic effects. So it can affect the smell, the taste, and it can affect the sense that people get when they have low oxygen levels. So generally, when people have low oxygen levels, they're showing up at the emergency room with an oxygen level with regular pneumonia of like 93, 94. With
Mm-hmm.
COVID, the severely affected people were showing up with oxygen levels of 50,
That's incredible.
which is incredible. So we're learning a lot about how to treat this, what it responds to, when to use steroids, when to use antibodies, when to use other things. But it's your immune response that really decides how you respond to it. Age is its primary issue. So if you look every single decade, it's a much higher group of people in the older decades that don't mount enough of a response to this virus and end up really, really sick from it.
Mm-hmm.
And the death rate is much higher by age than any other risk factor, any heart disease, any lung disease, any other risk factor. The next things are obesity, uncontrolled diabetes, and uncontrolled high blood pressure. This is the time you really want to get those risk factors under good control for your aortic disease, but also for COVID, for having hopefully less of an effect if you did get COVID. That being said, people who have underlying vascular disease, if you get a bad effect of COVID, it is an angiopathic or vascular disease. It hurts the vessels. People have a lot of clotting. They have a lot of inflammatory issues, a lot of cardiac issues, as well as the pulmonary issues with COVID. So if you're sick with COVID, the issues with your vessels can certainly be much more. And if you have unstable vessels to start with, it can be a much bigger issue. So we tend to be much heavier with blood thinners, with aspirin, particularly, or if somebody is developing clots or has a higher predisposition to clots, with full strength blood thinners. And we've learned that that is really life-saving because there's a lot of pulmonary emboli later with COVID.
Mm-hmm.
So treating that is important, and getting up and moving even when it really hurts
Mm-hmm.
is very important. And really doing lung exercises even if you feel exhausted, and then you rest. But you cannot just stay in bed with it. That's where you get really sick.
Yeah.
So getting up and moving and having the push to do that is something that many of the aortic disease survivors have already done, know they can do, and you have to do with this. So that combination is really important. And then the other thing I'd encourage everyone to do is to have the home pulse oximeter. So the little finger monitor, they used to be hundreds and hundreds of dollars. We would fight to have more than one in the office, like as office supplies. Now they're about $20 on Amazon on average, or you can buy them directly from manufacturers. It's just as important, more important with the current virus, to have one and use it regularly. And that will actually tell you if you're in trouble with COVID. So you're looking at the oxygen level. And then
I will say that with this virus, it feels like nothing. I felt like nothing I'd ever felt before. I knew structurally I just felt different, because with the flu or with pneumonia, that there will be light at the end of the tunnel. You kind of have an idea, after 2-3 weeks. With this, you just really don't know. You don't know how long before you start to feel better or what any repercussions are going to be. And you described it exactly. You feel like you can't breathe. So the pulse ox machine was really a saving grace, because if I looked at it and I saw it was at 98, then it didn't play with my mind as much. It helped talk me off the cliff, but you do not feel like you got 100%. So the poor individuals that were literally at 60 or 70, I can't even fathom what they must have really been feeling.
Here's a situation. This will tell you how life-saving this thing is and why everybody should get one. I had a patient I was very worried about. He's 19, but he has a single ventricle and passive blood flow to his lungs. He had COVID. He was at home, and I was following him a couple times a day, and he had his pulse ox that I had asked his parents to get him. He was quarantining in a room with his sister, who also had COVID. Sister, healthy 24-year-old, no medical problems, no aortic problem, no heart problem, no asthma, active girl. And she was taking care of him. So I was talking to him, I think the third or fourth night of their positive diagnosis quarantine. And his numbers were pretty good. His normal oxygen levels are 89, and he was running about 86, which in you would be a disaster, and him was a little bit low. But I could hear his sister in the background, and she didn't sound great. So I asked if I could talk to her, and I asked him to put his pulse ox on her finger, and it was 74.
Wow.
We called EMS. They took his sister to the hospital. She was actually put in intensive care and intubated, in her 20s. Had the monoclonal antibodies given, had remdesivir, had care, and 5 days later was actually home, recovering, and is actually doing fine. But she literally collapsed in the ambulance on the way to the hospital, would have had a full resuscitation.
Wow.
And it's really just because they saw that number that they were willing to call. They were so worried about the brother that they weren't thinking about the person that didn't fall into the high risk categories.
Right.
So that pulse ox really is for anybody who has this and should be widely available and regularly used.
Yep, you're right. So we have some comments. I have one more question we're going to get to if we have time, but let's go ahead and let's see if I can get some of these questions up here. Let's see if I know what I'm doing here correctly. So I'm not too sure if I go, where should I be going right now for this? This is still new. Okay, I think I know where I'm going. Bear with me as I find my comments here. And I think I need to quickly just, let me see if I can. I'm going to try to refresh this here and see if I can get into this a little bit. Let's see. I am looking on the screen and I don't see comments here. So we'll have to work on that a little bit. I have a question.
So hopefully after your initial dissection is repaired, you never develop an aneurysm. It depends sometimes on the gene that may be involved or the risk factors of why you had the aneurysm in the first place. For people that may have a gene that could explain why you have the aneurysms, they can affect other vessels and you can get new ones, just like the one that developed. Hopefully you never have those, but the screening would let you find them early so that they could be followed over time and so that they could be repaired potentially with more minimal methods, such as catheter-based methods, before they became terrible. The other thing about knowing the genetics and knowing how fragile or where the fragility is in the vessel, the surgeons are starting to have some different techniques that they would use for particular types of fragility. So that's actually really important. But you never have to have another aneurysm. If you have one, it needs to get followed more frequently than if you don't have one. And again, if you have these high-risk genes, then you need to get followed more frequently than if you don't have them. Hi, Tammy. Sure. So to address a little bit of all of that, first of all, I'm thankful that you're here and asking questions and that you have this support, because I think having this support group is critical and a really important part of this recovery. So to see someone like Karen here that's 6 years out and feeling really pretty good outside of COVID can just get you through the next month. Most people, it takes about 3 to 6 months to really feel normal to great after surgery, especially this kind of surgery. Many people say that it takes them a year till they really feel 100%. So you are still way ahead of the curve, and don't feel badly that it's taking some time to recover. At the same time, also don't just lay down. You have to get up and move. You have to push yourself a little bit and then rest, push a little harder and then rest. You have to work to getting your endurance and your energy back. So those are really important things as you recover. And it hasn't been very long since you had this happen. It's physically and psychologically just a huge change in life. And you have to recreate how you want to move forward and what you're doing. It also depends on what kind of job you have. So if you have a job like with heavy lifting, lumber, outside, extreme temperatures, that can be something that you may or may not be able to get back to safely. And again, it may be worth relooking at the types of things you can do with less lifting or less intense temperature changes. The pulse ox really for aortic dissection is not such an important monitor. It does help you with the heart rate, the pulse rate, and it helps you with the oxygen levels. So if there's any issues with the lungs or viral infection of the lungs or issues with asthma or fluid in the lungs from heart muscle disease, that's where that monitor can add a layer of understanding and know that you're safe.
You just mentioned something about work in cold weather, and that was the question I was going to ask. And I will say, if anybody has any questions that they want to ask, now would be the time to type them in. But if you end up seeing this video later, feel free to still ask questions. I'll get them answered from Dr. Fisher. But right now, crazy weather. I mean, we're going into lots of different extreme numbers here, but whether it's super hot or super cold, what does that do to somebody that has an aneurysm or has had a dissection, and what do we need to watch out for?
So the first thing, especially while we have a minute, is no snow shoveling.
No shoveling.
So why don't we like snow shoveling? Well, snow shoveling, number one, it's cold, so all your vessels are constricted really hard by the temperature. Number two, it's a very heavy isometric exercise. So you're basically squatting, lifting, and flipping. And it's usually very heavy. If somebody wants to lightly sweep snow or push a snow blower on, not something that's terrible, that's okay. But if you're really pushing and you're straining, that's the exact moves that we don't want for the aorta. So we like things that are kind of steady, that you could have a short sentence through, but not something that you're really bearing down and straining through. That's what's not good for the vessel itself. So snow shoveling specifically is cold. Your vessels are constricted. You overdo it with the straining isometric activities, which are the worst for the vessels, and then EMS can't get there. So you have this trifecta where we do have deaths every time there's snow shoveling. And again, we haven't, some areas that are getting hit right now, some areas even where we are in Maryland, have very intermittent weather episodes, so that it's not something you're regularly doing. You go out and overdo it once. And that's where you're really testing it out. So you don't want this to be a test. You want slow and steady, moderate level, nice kind of even blood pressure curve, and you want to be able to have a short sentence through your exercise. Hot temperatures, you dilate the vessels, you usually drop the pressure. Sometimes on the medicines you get dizzy because you actually are dropping the pressure. So just like a hot shower, the hot temperatures will lower the pressure. You need lots more water, and you need to make sure that you're not over medicated at that time. Sorry.
That's okay. I was checking, where's my phone? I realized it's yours. That's okay.
Telemarketer. Yeah, so that's going to be important.
Yes.
And it is possible sometimes to do like a low weight restriction, like maybe a 30-pound restriction on return, or switch to, a more scheduling or managerial position. So that's actually really important because most people do want to get back to work and have something to do. At the same time, again, I can't encourage strongly enough the vaccinations. And there is no reason having an aortic issue or a blood pressure issue that you wouldn't want to get vaccinated for COVID. You really want to get vaccinated because of those issues.
Well, and that's a good point. So just to wrap up the weather, extreme hot, you need to worry about becoming dehydrated. So you're moving a little bit slower and just making sure you're well hydrated. Extreme cold, you're going to have the potential of overstraining, overworking, and then people can't get to you if there's a major weather event. So again, we're into a no lifting situation, no isometric, and just go slower on those extreme weather patterns.
And get the aerobic activity.
Right.
Do the walking, do the the tennis, golf, things that get you moving, dancing, but not things that are straining.
Right. And we're going to leave this message with how important getting vaccinated would be. I know that there have been some people in the community that are a little reluctant, and everybody, this is a very powerful topic. This creates a lot of conversation on different issues and ways of thinking about it. But having an aortic dissection or having an aneurysm, whether you have an inflammatory issue or connective tissue disease, whatever the case may be, you're in a world of hurt worse if you end up with COVID than you would be from getting a vaccination. That's
absolutely. So many people do have a reaction to the vaccination where they have, usually the day after the second dose, some chills, low-grade fever, even headache, just a day you really feel exhausted. The next day, fine, which is what many people are describing. Some people really don't have any reaction, or feel very much. Most people feel a little bit of soreness in their arm for a day or so, which is nothing compared to COVID. And the other thing is that what you're feeling is your body making this immune reaction. You're feeling the response that it takes to fight off the virus itself, and you're putting yourself in it's probably the most important thing this decade you could do for your own health. And if you want to keep yourself out of the hospital, that's the way to do it.
I did find the questions. Yes, I found them. They popped up on my screen. We do have another question from a gentleman named Tom. He had a major dissection 4 months ago and had the T-bar surgery 1 month ago. And he wants to know, how long after dissection surgery can he have his teeth cleaned? And should he take antibiotics ahead of time? And we do get that question a lot. So I know that.
Great question. So it depends what's put in, but a T-bar is going to be some artificial tissue. And usually you want to let that tissue, normal cells grow over that tissue and give you a nice normal lining. So we like people, if they can, if you're having a dental problem, you go and you take antibiotics before you go. Outside of that, we like you to wait 3 months to have a dental cleaning. And within the first 6 months of any artificial tissue like Dacron or a stent, we like people to actually take antibiotics an hour before the dentist. Generally amoxicillin. If you're allergic, then it can be azithromycin or clindamycin. But we like people to take those antibiotics until normal cells grow over the tissue. So after 6 months, then you don't need that anymore.
Okay, that is great to know. I think I've actually hit all of the questions that were on my piece of paper here on my notes, that's great. And we've gotten some questions here, which makes me feel good because then people found us, which is wonderful. And it's always so great to see you and to talk to you. And we really do appreciate you taking time out of your evening and away from your family to join us and answer some questions and talk to the community. So thank you so much.
Oh, you're so welcome. Thank you for having me. And this is an amazing group of people, amazing group of survivors. It makes me hopeful to see everybody here and supporting each other, and I'll help any way I can.
It's wonderful. Thank you so much, Dr. Fisher. We'll talk to you again soon. And thank you so much, everybody in the community, for joining. Again, if you have a question, feel free to submit it, and I'll do my very best to get it answered as quickly as possible. Thanks so much. Have a great evening.
Bye.
Bye-bye.